Thank you, the organizers from Uttaranchal Orthopaedic Society, and especially Ruchit for this opportunity. And scaphoid again is a very often missed fracture. This is a 26-year-old male comes with a fall and a hyperextended wrist. Most of these patients come with the radial-sided pain, and you need to have some differential diagnosis when you start off with these kind of patients. The possibilities you need to keep in mind when patients come with radial-sided pain, obviously would be the most common one would be the distal radius fracture, and then you have the scaphoid. There could be scapholunate ligament injury. This is again one of the common missed injuries, because scaphoid, if it doesn't injure the adjacent soft tissue which gets injured, is always the scapholunate ligament. And sometimes there could be CMC injuries like Bennett's fracture dislocation and any of these. So these are the common radial-sided kind of injuries which happen when they come. And physical examination is very, very important, because if you see the distal radius, scaphoid, the trapezium, the metacarpal, all are very close to each other, and any of these could be injured. And then you have the scapholunate ligament here. One of the things you should remember is how the scaphoid is sitting here in the carpus, among the carpus, how it is oriented almost obliquely to a horizontal direction in the wrist, which basically means that classically we have been taught that anatomical snuff box tenderness is scaphoid fracture. But if you look at it carefully, the anatomical snuff box is generally around the waist area only, which means you can miss the distal fractures or the proximal fractures here. And if you actually really look by moving the wrist, when you put your hand into the finger into the anatomical snuff box, it's just only a part of it. So what you don't really uncover the scaphoid. So even when you palpate, if you do this movement like this, ulnar deviation like this, the scaphoid actually opens up and you can actually palpate a major portion of the scaphoid. So during your clinical examination, it's just not palpating here, but actually moving the wrist into ulnar deviation, radial deviation, and that brings out the tenderness. And that is one of the way to, not to miss these fractures easily. As I said, there are three parts of the scaphoid. Waist is the only one in the anatomical snuff box. If you want to look at the distal pole palpation, it has to be on the volar side. So its anatomical snuff box is lateral. This is volar, and for proximal phalanx, you have to go dorsal. So three portions of the scaphoid has to be examined in three different directions. So along your FCR, if you go, the first bony prominence you feel is the scaphoid tubercle, and that is where your distal pole tenderness will be there. And for your proximal pole, it's on the dorsal aspect. So you have the listus tubercle, which is easily palpable. And if you just go a finger breadth distal to that, you get the radiocarpal joint, which is a sulcus there. And directly where you put your finger is your scapholunate area. In fact, if there is a scapholunate injury, the tenderness will be there. If you go slightly radial to that, you have your proximal pole. So in essence, if you palpate the scaphoid in all three positions, volar, on the lateral, and on the dorsal, you will get all three parts of the scaphoid, and that's how we should not be missing them clinically. So that is where you will palpate dorsally, the scapholunate junction, and just radial to that would be your proximal pole. Can you increase your findings of these fractures if you're on clinical examination? Basically, you're provoking the injury. Like if you give an axial compression like this, it's similar to how the patient might fall. There could be tenderness there. This is called as a scaphoid compression test. And also a resisted pronation test also will give kind of a rotational force to the scaphoid. And if there is a scaphoid fracture, the patient might have pain. So this too, snuff box tenderness, tubercular tenderness, almost is white person sensitive. But if you add these compression tests, your specificity increases from about 20% to almost 75%. So by doing the provocative test, actually you can increase the yield of your clinical examination and not miss these injuries. So once you suspect scaphoid fractures, we commonly ask for X-rays, correct? And what X-rays is very, very important. So you have your wrist PA, you have your lat. So all wrist X-rays are PA views, not AP views. You should remember that the anatomical alignment of the wrist is better in a PA view. Then you have a lateral, and you also have an ulnar deviation view like this, where the scaphoid becomes in a fully extended position, and you might see the fracture line like this. The scaphoid series actually is 5 views. The other two are the oblique views. You see the oblique views here, and you see this area, the most distal corner here nicely, and the FTT joint here. So all these, if you put the 5 X-rays, your sensitivity and specificity almost about 100%. So this is another next step where you should not be missing the fracture. This is a patient, same patient whom I told initially, who came with radial sided pain, hardly anything, right? You don't see the fracture lines here. So the classic teaching is we put them on a plaster for about 2 weeks, 10 days to 2 weeks, and repeat the X-rays. And sometimes you might see the fracture line. So if radiographs are inconclusive, what do? Almost 25% are not visible on initial radiographs. So as I said, the classical teaching would be a cast, wait for 2 weeks, remove the cast and test clinically. And if there is tenderness, repeat the X-rays and take a decision. Same patient, 2 weeks later, you can start seeing the fracture line there. And this is because of the osteonecrosis which happens. This is a physiological phenomenon. The osteonecrosis which happens at the fracture area, that gives that clear fracture line at that point there. So if the patient is not willing for a cast, patient has tenderness, patient asks for a diagnosis, a definitive diagnosis, what you should be doing is the second line would be always an MRI. So if you don't see a fracture line and patient wants a definitive diagnosis, not willing to hold on for the cast for 2 weeks, the second line of management is always a MRI. MRI would show this edema, the fracture edema, within 24 to 48 hours. It can pick up the fracture edema there, and that's very important for you to diagnose. It can also pick up if the scaphoid was normal, if it is scapholunate injury, that also it picks up, or any other injuries around this. So your second line in the negative radiographs should be a MRI. It identifies the fractures of the other carpal bones and also the ligament injuries, and has one of the highest sensitivity and specificity. This is another 35-year-old male, again 1 day history of fall, pain, and you see the fracture. You actually see the fracture there, right? And you see that it's not a clear cut, a transverse kind of a fracture. There's some overlap here. There could be some combination. And these are the patients, if you want to decide whether I want to put a plaster or I want to do something more, in these patients, you have to go for CT. So the take-home message is that if you don't see a fracture, but you want a diagnosis, get an MRI done. If you see a fracture and you want to know the characteristics of it for you to decide between operative and non-operative management, ask for a CT, right? So surgical planning and diagnosis of any additional bony injuries. The most important thing when you ask for CT of these is that it has to be in the scan should be oriented longitudinal axis of the scaphoid. So you have to specify that please take the CT in the longitudinal axis of the scaphoid. It also helps in assessment of healing in later cases. The most important thing is routine CT. People, when you ask for CT, the routine cuts are 3 millimeter cuts. The radiologists or even the, wherever you send them for CT, they take a 3 millimeter cuts. Here, scaphoid is a smaller bone. You might just miss the fracture area, so you need to take 1 millimeter cuts in these patients. Only thing is sometimes it's difficult to diagnose occult fractures if you do CT as a first line. So CT will tell you the combination. CT will also tell you the gap. So as I said, to diagnose X-ray negative cases, you need to be doing MRI. And if you see the fracture line on X-ray, and to decide on surgery versus conservative treatment, you will have to get a CT done with that 1 millimeter cut. So this is about how not to miss these, both clinical examination and your basic X-rays and advanced imaging. So these are the 3 steps. You'll have to do it in a proper way so that you don't miss these fractures. But once the fracture is diagnosed, the dilemmas start: which ones to treat non-operatively, which ones require surgery, what is the method, what is the implant. So the most important is how stable the fracture is. That is very, very important for you to tell whether non-operative is required or operative. Where is the location? Is it waist? Is it proximal pole? Because your management changes. And of course, patient factors in terms of early return to work and their demands. So if you look at the Herbert's classification, stable fractures hardly 1 or 2. The distal most fracture here and an incomplete fracture through the waist. It's almost like fracture neck femur, right? Similar philosophy here. Most of them are unstable fractures. If the moment it becomes oblique or full fracture line, and as it goes towards the proximal pole, they're all very, very unstable fractures. More than in fracture scaphoid, we talk of millimeters, 1 millimeter displacement. In distal radius, we talk of 2 millimeters. So in fracture scaphoid, it's more than 1 millimeter displacement. If you draw this angle between the two two fracture fragments, it's called the intrascaphoid angle. More than 35 degrees is unstable. Any bone loss combination, all proximal poles inherently are unstable fractures. There's no role for plaster and conservative management in this. And of course, if there is a DCA alignment because of perilunate fracture dislocations, they're all very unstable fractures. So your closed treatment works when it is stable and it is non-displaced. And we know the cast immobilization with the classic glass holding kind of position to prevent displacement. You need to maintain the immobilization long enough for healing, generally between 6 to 8 weeks. So this kind of a thumb spiker cast for 6 to 8 weeks. Sometimes you might go to 12 weeks. You might have to tell the patient that you might extend the cast if they're not healing. Especially you need to ask their history, smokers, and people using tobacco. Definitely the healing is always delayed. So always document it. As a surgeon, you should be asking that and documenting. And sometimes we might put a long arm cast for a non-compliant patient. Wrist in neutral position, IT joint can be left free. Almost up to 93% union rates are seen as long as they are stable and non-displaced. If it is unstable or displaced or comminuted, you would require operative management. And you have to think about or talk to patient also what they want, especially young patients, active patients, athletes, patient with high demand occupation, and who want to go for early kind of range of motion. Percutaneous fixations, open method, arthroscopic assisted. And sometimes even in acute fractures, we might use bone grafting. KYs are still used, very proximal pole fractures, open injuries. Otherwise, generally we go for a headless kind of a cannulated screws here. The percutaneous fixation, I think all of us should acquire that skill of doing it, especially for scaphoid fractures. It is a biological kind of a fixation because you don't open the fracture site, and it's always used in stable fractures. But if you can reduce the fracture, then you can still use that. And the entry, generally Oler approach is used. Very difficult to get the central axis of the scaphoid, especially with the trapezium being there. So you'll have to dorsiflex this completely so that you get access to the scaphoid as much as possible. And difficult to get a central axis from the Oler approach here. So this is how you do a percutaneous fixation. This is how you draw the axis of the scaphoid in the AP view like this along the axis. You keep a wire there, you draw the axis. And again, in the lateral, you keep the wire like this. And so the entry point is basically where the meeting of those two axes happens. So that is where the point is. You can use a 14 gauge needle like this. And actually that will act as a kind of a sleeve for your guide wire. Or even freehand you can do once you're comfortable with it. So this is how you need to check both in all the directions. You should make sure your guide wire is in the central axis as much as possible. So this is the most important step because after this everything happens over the guide wire. So sometimes you can screen and make sure you see that the wire is completely inside the scaphoid in the 360-degree view. That's very, very important. This is the most crucial step for your percutaneous fixation there. And once that is done, everything happens, as I said, over the guide wire. So spend a lot of time there to master this, and don't go in with repeated drill holes there. And once that is done, make a small incision there. That is where your drill goes over that. Just spread the soft tissue with an artery forceps there. And then you take the measurement with this measuring device. And generally what we do is we minus almost 4 to 6 millimeters here, because the scaphoid is completely covered by cartilage, both proximally and distally, and there's a fracture gap also. So don't use the same measurement, minus it by between 4 to 6 millimeters, and based on that you take that. After your drill, this is the compression, it's called the compression sleeve, and you fix the screw there onto that. And once you do that, this screw will go just about 2 millimeters outside it stays, and just about compresses the fracture site. So that is what it is. And once that is done, there's another screwdriver here. This is one particular instrument set I'm showing. There's no conflict of interest there. So this is the other screwdriver where you have these three markings here. So this first one is where just the compression screw are put the screw. This yellow mark means it has just gone flush with the scaphoid, the pole there, distal pole, and the red one says it's 1 2 millimeters inside the scaphoid. So that's how it should look. And again, check in both PA and the lateral views. So this is one technique I mean, the younger surgeons should definitely master this. Open techniques, when you can't reduce by closed methods, and especially in combination, volar approach is used for distal third or midwaist fractures, and it's very useful to correct the humpback deformity. And we know that as a blood supply comes from the dorsal aspect, so volar approach is good and it gives a good visualization, except that you're cutting through the capsule, so it might cause some scarring and some amount of stiffness there. This is the classic volar approach, a hockey stick kind of an incision or a J-shaped incision here. A small, this across the crease, you don't cut it right across the crease, you make a small bend there. And this is through the FCR tendon sheath. So this is the FCR there, and that is the FCR sheath. You cut through the FCR sheath here and go distally. And then what you do is you cut through the capsule through and through to enter the joint. So you drag the FCR here at this point and just cut through it. So there is a capsule here, this capsule, make a single cut. There are different types of incision. There is a plastic and so many other things, but it's easy to suture. There's a straight incision here, and once you're going, you're straight onto the carpus there, and you see the scaphoid underneath this. So you're just stopping at the distal edge of the radius articular surface here. So once you see that, you see the scaphoid there, and you can see the fracture site at this point. So that is your scaphoid, and that's a scaphoid there, and you can see the fracture site there. The rest of it is the same, like your open injury. I mean the percutaneous thing. You pass your guide wire there over that, and you check again clinically and under C-arm, and then the drill goes in, and then that is the screw. Right. So the rest of the steps are same, except that you're seeing everything is seen openly there, and you can check the scaphoid, you can screen and check, and then the capsule is closed nicely, so that you get a good closure and you can start mobilizing the ring. This is another patient. If you see, this is a proximal pole fracture, inherently unstable. So you don't put them on a cast and wait, because most of them don't go for union here. They're very small fragments. The blood supply is not good. They're intra-articular. There's a lot of stress because there's a longer lever arm. So they're all both displaced and undisplaced are unstable and require fixation. Dorsal approach is advisable for proximal pole, because that is where you can put it in a central axis like this. Only thing is the wrist needs to be hyperflexed, and it can cause humpback deformity. Okay. There are many techniques, again, percutaneous or mini open. So this is the dorsal approach. This is, you flex the wrist like this completely, and you will see the end-on view of both the poles like this, the distal and the proximal pole. That is where your entry point is at this point. And then you put in your guide wire here. Only thing is now the wrist is bent here, so you can't take a lateral view. So what you need to do is to come out here and get the wire in flush to the dorsal aspect here, and then you can extend the wrist and get the lateral view to check your guide wire here. Whether it is the central, you can put another wire as an anti-rotational wire, and then the screw goes from the proximal aspect to the distal aspect like this. Okay, and if you don't get that entry point, you can make a small incision here, a mini open. You can visualize the proximal pole here, and then do the rest of it the same way. Measure and then put the screw here. You'll get a very small cartilage defect like this at this point. One of the, if it is minimally displaced like this, you can reduce it. Like you put in joystick wires like this, and you can reduce it like this, and then still go by percutaneous technique. You don't have to open it. So you reduce it like this now, and then still you can do the percutaneous technique like this. Sometimes we use an arthroscopic assisted I'm sorry, it's not playing. So basically, one of the new techniques, one of the new skills, not necessarily it's always done, but you can visualize it completely arthroscopically, and then you can do this. So should we fix all acute fractures is the question. So one of the mid path is an aggressive conservative. See, so all undisplaced fractures, we put them on a cast. Then we take at about 6 weeks, we remove the cast, examine for tenderness, take x-rays. And if you see some fracture gap and there is, there is a clinical tenderness, you take a CT scan. And literature has shown that anything which is less than 2 millimeters, you can continue the cast for 2 more weeks. Generally, they heal. But if the gap is more than 2 millimeters, a percutaneous screw fixation would be the ideal way so that the patients don't end up with non-union. So at about 6 weeks, you're taking this decision whether you want to fix it or you want to further immobilize in a cast, and then take a decision so that these fractures, these acute fractures, they don't go for non-union. So this is called as an aggressive conservative treatment for stable fractures, especially. So take home points: MRI is the second line of investigation if you don't see the fractures on X-ray. But if you see the fracture on X-ray and you're in a dilemma whether to operate or not, so take a CT scan, 1 millimeter cuts in the long axis of the scaphoid. And if you see combination or gap, you can go for fixation. All unstable fractures require fixation. I told you what is instability in this scaphoid. Percutaneous technique is a skill which is essential or which is desirable to master because it causes least vascular disturbance, because you know the scaphoid vascular supply. And sometimes, again, a new skill which can be acquired is arthroscopic assistance so that we can avoid open procedures in future. Thank you so much.